QRS and every other thing that gets thrown our way. And so they asked me to come today to talk a little bit about patient-centered medical home, and you guys are in the process, whether you believe it or know it or not, of going through patient-centered medical home. And I know that some of the policies and procedures have already been written on behalf of everyone and how we're doing things. Typically when we see patient-centered medical home, people are going through patient-centered medical home probably for the Blue Quality program from Blue Cross Blue Shield. It's a requirement of their Blue Quality program. And it's an incentive that has basically helped our state to be pretty high, have a pretty high number, about 600 practices in the state that are patient-centered through NCQA. And in the nation, there's like 6,800, which to me didn't sound very high. But you know, a lot of states and in a lot of the states, there are no incentives like Blue Cross is offering to help folks, you know, to join the patient-centered medical home. And it was really quite a new concept for the last 4 years. But now when we start talking about ACO environments and things like that, it's a requirement. And so you want to make sure that you're staying on top of that and moving towards what you need to for patient-centered medical home. So I'm going to try to briefly go over some of what patient-centered medical home is and how it basically affects you all. So it's really kind of interesting speaking to physicians about patient-centered medical home because you do everything right, right? So everything you do with your patients is right, and it's good, and it's working because your patients are hopefully getting better if they can, and you're having some good quality care. But a lot of things we don't document what we do, and everybody doesn't do the same documentation as the next person. And so what we try to do is see where we are short on some things and then build upon what we have to. What I found with working with practices on patient-centered medical home, there are some things you have to change to be patient-centered. And after you change those things and you're in this patient-centered medical home world, you start to say, hey, this is pretty neat. We should have done this a long time ago. Honestly, that's going to happen, believe me. And it's really interesting because the physicians will see things differently too. Patients see things differently. They'll see that things are changing. You know, there's some things that are happening that they hadn't seen before, and you're going to be asking them some questions you may not have asked them before. And we're just going to try to continue to document that as we have in the EHR system. So you're using the GE system and have been using that since '92, which is amazing. So a lot of what we're going to see for patient-centered medical home and what we need for reporting is coming out of that EHR system. We haven't decided on conditions yet, but we kind of know, which is typical in most practices. You can pretty much guess what they are in the top 3 conditions of your population here. Some practices like to try to get a little crazy and think of some things they've always wanted to do in their dream world, like obesity programs, which they have not even started. And I don't recommend that because it's very difficult to get something up and started that you haven't even thought about how you're going to go ahead and do that. So you do things that are already out there that you're doing very well. We want to kind of just hone in on that. This isn't a challenge to do something off the wall or something you've never done before. This is just showing the NCQA that you do what you need to do for patient-centered medical home, and you are a patient-centered medical home practice. Once we branch out from patient-centered medical home, there's patient-centered medical home now for specialists. So we'll close that loop of sending people off to, and you guys are lucky because you're all here in this one big happy family of physicians. But the outside world, you know, they're sending somebody over to a cardiologist, and you don't even know if they ever get there or what they've done, and you know whether or not they've been seen and what happened. So we're trying to close that loop. I don't have really a whole lot to do with the NCQA and patient-centered medical home on making sure that our patients are doing what they need to be doing and going where they need to be going for the care that they need. So feel free to raise your hand and ask questions, or don't raise your hand and just ask questions. I did this today at lunchtime, so this is my second time today, so hopefully I don't talk too fast. Okay. And by the way, I've worked with practices about over a dozen now on patient-centered medical home in the state. One of them just came up with a level 2, but they're very rural practice. Everybody else was level 3, and that's the highest level. So your level 3 is the highest, level 2 is mid, and level 1. And then there's also a no level. If you miss some items, you can get a 0. So you've probably have read or heard about the triple aim approach, and you know it's the framework for healthcare to improve patient experience, improving the health of populations, and reducing the per capita cost of healthcare when possible. And so when we're transforming the primary care into what the patients want, and this is the kind of things that as an organization you probably already have, but you know how we have to sort of prove this to NCQA. So we have to document this. We have to show this in screenshots of our computer system and patient charts and our policies and procedures and things like that. And so that's kind of where we'll go with this. And they're already working on that on your behalf. But we may ask for your input on certain things that we need some help with, some guidelines for some specific conditions and things like that as we go forward. But the whole goal is lowering costs. Everybody's trying to keep people out of the ER. The hospitals don't want to see people coming back into the ER. There's the new Medicare Transition of Care Code that pays pretty well, but we as an organization have to make sure that we're doing what we need to do with those patients as they come out of the hospital to keep them from having to go back in again. So the endorsements of patient-centered medical home, because a lot of folks wonder where does this all come from? It comes from pretty much everywhere you can imagine. And it's interesting that we have a lot of specialty organizations that actually endorse patient-centered medical home, but they had no way to prove they were in fact ever patient-centered until last year in March when the new patient-centered medical home for specialist criteria came out. What we're seeing in the state here for the specialist is that the Blue Cross Blue Shield is looking at that when they're looking at their quality measures for their tiering on how they'll get paid going forward too. So they're going to be doing the same type of work as you guys are seeing here. So, and I apologize for my graphics aren't there. Last time I presented we had the same thing as the computer or something, but that's just the logo that you can see. So there's, like I said, 6,800 and over 500 in North Carolina that are already recognized patient-centered medical home through NCQA. And there are other bodies that actually can recognize you. URAC can do that as well, but Blue Cross doesn't accept URAC as one of their folks that they'll allow you to use. And then JACO does this in the hospital. You may be familiar with that. So the way that the process works is that there are 6 must-pass items, and like I said, you have to pass them. And it used to be, if you've ever gone through this before, you didn't have to pass all the must-pass items according to NCQA. You could pass some of them, not all of them. But in the 2011, they required that you actually pass all 6 of them. If you don't pass these 6 items and you miss one of them, then you actually get a 0 no matter how much work you've done. So these are extremely important to make sure that we nail them down. We do 100%, if not more, on every single one of them. If you get a 50% mark on any of these, you could pass, but I don't like to challenge that, the practices on that. We want to make sure that we do everything we can do, and it's not that difficult to meet a lot of these things. We talked a little bit earlier about some of the pieces that are done in 3C and 4A, and those are done on a workbook, and so what we might probably want to do is just do some audits of charts to kind of see where we are with these particular things. But access during office hours is one of the things that a lot of practices will do, where you sort of build in, and we can always add some more people on the schedule and that type of thing. But what they want to see is that you actually have spots on your schedule designated for open access. And this kind of sounds scary because people say, oh my gosh, we can't see any more patients, but your facility controls those spots, okay? So if we added a spot and you're done at noon, and we added a spot on the schedule for 12:15, your scheduling people understand that if you're going to put somebody in that 12:15, there better be a darn good reason why, right? Because there's other places to put them. But the goal is that if somebody calls the office in the morning, there is a place for them to be seen on your schedule. Interesting enough, access during office hours also includes well visits as well as sick visits, which is kind of impossible to actually just throw into the schedule. But you have to allow for that to happen if somebody should ask. But I think we all have well-trained patients who understand that you just don't call a day up just because you feel like it and come in for a well visit. So usually it works itself out. But when we're documenting all these processes, we have to make sure that we allow for that if somebody should need to have a well visit. Data for population management, you all have been doing this for a while, whether you've seen any of the reports or not, but we're using these reports with Medicaid uses these reports for you, Medicare uses reports for you. Blue Cross can provide some pretty good reports on your population management as well. And then the care management is, like I said, it's sort of like chart audits, if you've ever gone through chart audits, to kind of see if we've been able to document some of the pieces that are involved there. And the self-care process is very important, that we sort of ignored over time sometimes of whether or not our patients are actually capable of self-care and what we need to do to support that. Referral tracking, most practices do a really great job of sending referrals out, but like I said before, not really so much of the follow-up. Did they really go? What happened when they went? And did I get that report back? And then 6 is trying to put together some quality improvement for your group. And a lot of times this doesn't have to be too much of a challenge because there are some things that you naturally have improved upon as an organization. And so if you just kind of look back into some of the things that you've done before and you say, well, we had an issue with, I'm going to just go blank, making sure we did an outreach to all women to make sure they had their mammograms, and we did this big campaign, something of that nature. You can use something like that as a quality improvement piece to show what you had, what you did to improve it, and then that you had some improvement along the way. They actually don't actually require improvement in that 6C, but it's nice to show. So a little bit more about the access during office hours. This is a must-pass item. So you can see what they're asking for. They're asking for you to provide the same-day appointments like I talked about, providing timely clinical advice. And this goes from having a policy in place as to what is timely clinical advice. What is timely? What do we have as timely here? Do you have it?
Policy is within 4 hours they have to call them back.
Okay, so somebody's calling back within 4 hours.
4 hours.
Okay, during office hours. And then there's another one later on, it's not a must pass, but you know, what are we doing when we're closed? How are we getting back? And so this is kind of things that you may have been doing all along, but you didn't have a documented policy for. So if somebody were to come in and say, hey, how do we do something? You'd have a policy in place for it. And everybody across the whole organization would be following that same policy. We would then be able to see whether or not we're able to return our calls during office hours during that time period, and that's important to know, because if we're not, we got to figure out what we can do to help that process. And you don't have to pigeonhole yourself into saying we're so great, we're going to return our calls within 1 hour. You can, it's your definition of timely is what's important, okay, and that you stay with that, so that if we did an audit of phone calls coming in on advice, that we'd be able to say we've met that. You know, our turnaround time is 24 hours. Everybody's been called back before 24 hours or 4 hours or whatever it is.
4 hours is urgent, 24 is routine.
Okay, and that's the other thing. So good, thank you. So we have different criteria for returning those calls too, whether it be urgent or not. Things you've been doing all along. Timely clinical advice by secure electronic message, probably not happening yet, but the portal's coming, right? So when the portal comes, these electronic messages will come through, and most of the portals don't allow those. They're not coming to you directly as a physician. Somebody is getting that, just like the advice nurse is getting those calls and then deciding where they need to go. But whether or not you can do that. On that particular element, all of these are a yes or no answer, and then documentation to prove. But on this one, if you don't have the ability to do secure electronic messages, you can take an NA, which actually counts as a yes, which is great. So it gives you the points you need for that. Documented clinical advice in the medical record. So we're giving advice, but we want to make sure that we're documenting that in the clinical record. And is everybody going to put that in the same place, and so that we'd be able to see what that clinical advice was, making sure that that happens. And then a policy in place that as we hire new people in and we get a new nurse in that's giving clinical advice, making sure that they understand where they're supposed to document that and how they should document that within the patient's record. So all of this leads to these types of things. So the practice provides the electronic access, the patient selects their clinician, and it's a team-based focus of patient care. There are practices out there that the patient has not chosen a primary care provider, and so they keep going to various different people, and it's not only hard on the patient, but it's hard on the physicians, because you don't know this patient, you don't know their history, as well as you would if they try to keep coming to you. And that's an important part of patient-centered medical home, is that you get to pick a physician, and you get to see that physician whenever it's possible to see that same physician over time. And then that kind of keeps the routine care in order. Population management reporting. So on this particular element, the things that the team here is choosing and trying to figure out with your help are at least 3 different preventative care services, at least 3 different chronic or acute services, and patients recently not seen by the practice and specific medication. So what we see on that is that we would look at 3 different preventative care services. So we say maybe our colonoscopies, our mammograms, and our influenza shots. And we're going to look at those 3 services, and we're going to see how well we do with asking patients if they've had these, if they fall within the range that they should have had them, how well are we making sure that that happens. And that, again, we have to think about is an outside source. Is that internal if they get a mammogram? Yeah. So you can see that. But what happens when we ask them to do it and they don't do it? Now it's 3 years later and they still haven't gone. You know, how do we follow up and make sure that we get our patients to doing these things and that we are continuously reminding them to do so? We can't make them do anything, but we can keep reminding them that they need to go and trying to do what we can to help that and find out what the reason may be that they're not going. And then 3 different chronic or care services, which could be some of the same thing, you know, diabetes, it could be our foot, you know, foot exams, eye exams, things like that. Patients recently not seen by the practice. A lot of practices, when they have an EHR and start using it the way they should, they find out that they can actually see reports as to what patients they haven't seen in a while. So they can run a report and look back, you know, a couple of years and say, how come I haven't seen these patients? These haven't been in here for 3 years. And then we have to find out if those patients are still out there somewhere that they could come to our practice, or maybe they've moved away. But there's some outreach we can do and say, hey, we haven't seen you in a while, we'd like to have you come in. And it brings those patients back into the practice where they should be so that we can continue to handle their care. And you'd be surprised at patients that are really surprised when they get a card or something in the mail that reminds them that they haven't been seen in a while, because we all put it off because we just don't have time. But you know, they appreciate that, and you'll hear from them. Specific medications, so we want to make sure that, you know, if there is a drug recall or something like that, that we can run list of specific medications, which we can out of the system, and then be able to either notify those patients or at least send them a letter telling them they should talk to the pharmacy. The 2D on the specific medications has been quite a challenge with some of the practices, because technically the pharmacy is the one who distributes that medication and knows the lot numbers that were recalled. We don't know that when we're prescribing, and we also don't know whether they gave them that particular either brand or generic that might have been recalled. So I personally feel that the specific medication recalls should be done by the pharmacy, but that's just me. If you do some outreach on that, typically, then that's where we would be using that specific medication as something that we can use for the population management and how we alert people from the practice side that there's been a recall, or maybe there's a new medication out that you want to let them know about that's supposedly better than what they've been taking. And so then, all in general, we're looking at, for that particular 2D, the practice collects demographic and clinical data for the population management, and they're looking at and documenting the risk factors for patients, and then identify patients for proactive reminders. And that you can do those proactive reminders in so many different ways within the system itself. Is there any questions so far?
You list all the elements, but how do they measure those elements?
Oh, good question. Well, we have to document. Your practice has to document, so you'll be running reports. You'll be doing screenshots to show, like for instance, if they want to know if we're asking patients whether or not they have a self-referral, for instance. You would show a screenshot as to how your GE system is asking that question, you know, showing you that that's on this template that you should ask that question. And then we'll be able to maybe run reports. Usually we can't run the reports on that particular item, but we're documenting by showing screenshots, running reports, and being able to show them the data that sort of proves what we're saying we're doing here.
So they're going to audit the chart and find out whether you meet the criteria?
Your team will be doing that.
Okay. Because some of the criteria is easy to measure, like 3 preventive services.
Mm-hmm.
Probably we get 100%, but like same-day appointment, how do you make judgment when we provide same-day appointment? Because
yeah,
does that count if I have a same-day walking spot? Does that count 100%? Or like every patient calls the same day they get appointment?
Yeah.
Actual appointment they get.
yeah.
So I don't know which
Yeah,
county.
and it could be either way. It can be shown either way. So a lot of times what we'll see is that basically they've called in to say something's wrong, right? And then when they've called in and said, I think I need to be seen today, either the advice nurse has called them back to talk to them to find out what's wrong, and then either schedule them an appointment today or whenever they need, or where they need to be, right? So you basically follow through the process of a single patient, which has to then represent the whole population, because we can't do it for everyone. So we're showing an example. Here's a phone call that came in this morning from this patient who said that their ear hurt, right? And then that patient, the advice nurse said, you might want to come in. And the doctor has an opening at 10 o'clock that day. And then we're showing all that as documented process.
Right, but what happens if we don't have appointment that day? How would that affect the whole percentage?
Well, we should always have an appointment or 2 for every doctor per day.
Right,
Oh,
but
You just show that
Just on the
appointment on the
spot.
schedule, on
Yeah,
the
you would
spot,
show the
just
schedule.
have it, whether it gets filled or not.
Right, we
So on the
always have.
template, you just have it assigned.
So that count,
Right.
okay. So I was worried if we have 2 appointments assigned, but then 10 patient call that.
Yeah.
No,
Got it.
they
So
just
that's
have to
it.
show it on the book.
Just
and
shows
then
that,
save
show
it.
that you have those available.
That's-
Yeah, sorry. And then evidence-based guidelines, so this is where, you know, your expertise comes in, because when we decide what those first important and second important condition are, which might be diabetes or hypertension or something else for you all, or asthma, we see a lot in the pediatric practices, we're gonna decide what those are for the group, and then we're going to be able to report on the evidence-based guidelines according to what we're supposed to be doing. For instance, if the first important condition is diabetes and we want to make sure that everybody's getting an eye exam and a foot exam and whatever else they need tested, then we're going to have those things mapped out within the system. We're actually able to run some reports from the GE system to be able to see where we are with doing that for those particular patients with those particular conditions. So that will be handled. But are we all following the same guidelines? That's the question, right? And we all should be, because there's some guidelines that are published. What would we use for diabetes? What guidelines, the diabetic? American Diabetes. Yeah. So you would use that for the guidelines, and then we just kind of want to look at the whole group and say, okay, is every doctor sort of doing the same thing? And that's how we'll be able to run the reporting to make sure that we are asking the same question. And that's very simple to do, and it kind of seems silly for me to ask that question to somebody that's been using an EHR for all these years. But you'd be surprised when people didn't use an EHR, right, that there was no uniformity, because everybody's sort of doing their own thing. So we didn't have a template that reminded us of what we need to do. So it's a lot easier. I won't do patient-centered medical home with somebody that doesn't have an electronic health record system, although you were able to do that before. But it's just so much easier to be able to do that when you have one. And it's hard to understand, you know, how anybody can do it any other way. But that's that. So the third condition, though, we pick, so we might be able to pick the diabetes and hypertension, but the third we have to look at unhealthy behaviors or mental health or substance abuse. What did you guys think of for that one?
We're looking at obesity for that, but we're
Obesity?
still kind of playing around with
Okay.
what we want to pick.
Okay, so we've seen some ADHD on that. No? We've seen depression, because there's depression screenings that you do. Smoking, if you have a way to help them stop smoking. Is that Yeah, yeah. So that's where it's important, you know, to kind of figure out what those are and then how we're going to go about measuring that for that third important condition. But it has to be a behavioral or health, mental health or substance abuse type of condition for the third. But it's interesting. So that's where, like, my practices would say, well, we've never done anything on obesity, but we're going to do this whole big obesity thing, and so now we're starting from scratch, and, you know, we've got to put everything together and build it all out. We have no proof that what we're going to do is going to actually be working, so that doesn't work real well. So we have to try to look at something that we already know we do well. Nobody's challenging us to say, you know, pick some kind of a rare condition that you hardly ever see. They want to know what you see and what you do well, and we're just going to be documenting that process. It's not too difficult. But what you may find is that when the girls are running, and the gentleman, whoever's running the reports in the background, would find that maybe we're not all doing the same type of thing. And it's kind of hard to do when we have templates, but if that becomes the case, then they may have to talk about a workflow change. We're making sure and asking you, please don't forget to do such and such for these patients. And it's only, you know, 2 important conditions and 1 unhealthy behavior. And you know, you see a whole heck of a lot more than that, I know. But this is what we're concentrating on, right? So the hope would be that once we got these down pat and we went through the patient-centered medical home, then maybe you would say to yourself, well, we're not really doing such a great job with our smoking folks or people that smoke and stuff like that. So maybe we put something in place where we're going to try to challenge ourselves to do a better job of that and try to do more with that. But it's not about NCQA, I shouldn't say challenge, because it's not about a challenge. It's just showing them what you do well, okay? They're not trying to challenge you and say, well, you're not as good as the next guy. You're just showing them that you are patient-centered with the patient-centered care that you have. So care management. So some of these things, a lot of times when physicians see that, they say, well, yeah, I do pre-visit prep. And then you ask them what it is, and they really don't have anything. So, like, if it's an asthma patient, you know, do we have any kind of forms they're filling out or something we want them to do online? Or, you know, for peds, I know there's a lot of different forms and types of questions that the parent needs to ask for the child, is asked on behalf of the child. before their visit, so that when the visit happens, we're asking them, we already have the questions answered, instead of them having to answer them there. And that's kind of wide open. People have done a lot of different things on that. Develop an individualized plan of care, and so you guys see it, the different populations that are coming in. So sometimes, I was coming in and it looked like it was a daughter coming out with maybe her mom or something. So, you have somebody bringing someone in. So you have to explain to the patient, but you also explain to the family member, and then kind of in your mind, thinking to yourself, do these people really understand what I'm trying to tell them that their treatment goal is, and do they fully, are they fully engaged in what I'm trying to relate to them here? Because that's the only way they're going to get better, if they know and understand what they need to do. Written plan of care, we do a pretty good job of that, because that summary of care that comes out of Meaningful Use actually provides that now in writing for the patient. If there's any barriers to their care, you have a whole community here in Greenville, so that if you kind of notice that somebody might need some help, maybe it's a senior citizen needs some help, you know where to go and ask for them to go talk. You know who to send them to in your community. And it could be anything. It could be, a workout place, or, a spa, or some massage therapy, or whatever they may need. Just to know and have those resources available to your patients, very important in the patient-centered medical home care. Even things like WIC program, or Meals on Wheels, or something like that. Know how to get that help for your patients if they should need it. And then the same thing kind of applies for 6. And then follow up with the patients who haven't kept important appointments. We all know how important that is, especially when it's a well visit and they miss it, because that really sets us back in many ways. But we want to make sure that we're following up with people when they don't keep an appointment, and making sure we get them the appointments that they need over time. So this is just kind of saying, assessing their progress towards treatment goals and patient barriers to goals, and med reconciliation and hospital reports. Are you guys getting information from a hospital here? No? Who's the hospital?
Epics.
Epic, yeah. Well, that's coming because of the NCHIE will have that information for you. So you'll get